Hello everyone, this is Fire Chief Paul Dow with Albuquerque Fire Rescue. This podcast is designed to bring you helpful training and best practices and some additional resources that you can access from anywhere. So thank you for joining us and enjoy today's episode.
Alarm 2, Rescue 5, Engine 578. Rescue 5, Engine 578, respond out to 500 Louisiana Boulevard Northeast. It's going to be a Princeton Place rehab. Responding out to a 72-year-old male, not conscious, not breathing. It's going to be in the lobby. 9 Echo 1. Engine 5, Rescue 578. Princeton Place rehab, 500 Louisiana Boulevard Northeast. 9 Echo 1 in the lobby.
Good afternoon, AFR. This is the B Shift 78, Clint Anderson here. I'm joined this afternoon with Kevin Ferando, our C Shift 78, and another paramedic extraordinaire, Mr. Jeff Ruscetti, Station 5C. We're joining you this afternoon, or we're entertaining everyone with a cardiac arrest discussion. We're going to talk about really just the nuts and bolts of the cardiac arrest guidelines that we have set out by Dr. Pruitt. And again, I've brought this company so that hopefully between the three of us, we can encompass all the expectations as well as, in essence, how a cardiac arrest should be run within Albuquerque Fire Rescue. So again, having the experience coming out of Albuquerque's infamous Southeast from Mr. Ferando, Mr. Ruscetti, and myself should have enough combined experience to be able to get you guys some good knowledge here. We're going to start off here at the outset just talking about our ECMO program. We're not going to go into extreme detail, but we're just going to re-emphasize the criteria for ECMO, the availability, and what may apply and not apply right now in this current COVID-19 debacle we find ourselves in. Kevin, you want to comment on the ECMO criteria real quick?
Sure. So the way we have our ECMO call out decided, it starts with the alarm room, and they're really the kind of the cornerstone of this. They ask the questions that sets up whether this is going to be a candidate for ECMO and if this is going to generate the dispatch required for that. So some of the questions they ask, it's an inclusion criteria that we're looking for. So ages 18 to 75, preferably a witnessed arrest, but we're kind of gotten a little bit more lax on that. Bystander CPR, and then at this point we're going to start getting this machine rolling, the ECMO truck fired up. So we'll actually do a separate dispatch that gets the ECMO truck, which is stored at Station 3, activated. Once that's one step of it. The other step is clearly the initial dispatch, which got that first crew responding to this patient. So that's going to be as business as usual. Our first arriving unit will get there, assess, kind of re-evaluate the inclusion criteria, and then they'll start just going down the normal ACLS protocol, write down the algorithms, and then, when ECMO does show up, we turn everything a little bit over. It slows down, so to speak. The docs start doing their doctor thing, where they really start getting this patient set up in a semi-sterile environment in a truck that we have dedicated for this procedure. It's pretty fascinating. It's very coordinated. So far, we haven't had we've done 3, Clint? I think now field 3 or 4. Mm-hmm. And yeah, that sounds right. Unfortunately, we haven't had any of these people who had a good recovery. We have got them to ICUs. Unfortunately, I don't think that any has made it past 4 days or so in an ICU while being on an ECMO machine at the hospital. But that's not to say that it's not going to happen. We're looking for these people who are in that refractory V-fib who we can really change. A lot of the ones that we've had are the only ones we've had right now. Either there was probably a longer downtime than we suspected, or the medical condition that generated their cardiac arrest was not reversible. So I know a couple PEs, and I'm not sure what the other one was, but it was just, unfortunately, the outcomes were not as what we were hoping for.
Just to jump off of that, and we'll chime in later about the effectiveness of ventilation, oxygenation, and trying to avoid that anoxic injury in our patients. But is ECMO available right now during this quote-unquote healthcare crisis, or?
Yeah, as of right now, our ECMO call out is on a standby, so we're not going to be doing any field cannulation. So that, not to say that you can't take a patient who does start fitting this criteria to UNMH for ECMO procedure. We're really trying to keep this 35-minute from collapse to cannulation time. So if we have a patient who's on the outskirts of the city that just is not going to be within that timeline, it may not be beneficial to try to initiate that transport. And that's a tough decision to make. The docs are still at UNM, and they still are doing the procedure, but they're just not doing it in the field.
Sure. And I think all that being said, I wouldn't want any of our rescue lieutenants or any of our personnel, period, to hesitate to call us while we're inbound, because you guys are the first ones on scene, especially at these outlying stations, to get our 2 cents. Because if you have that, what we like to refer to as a spidey sense in our super scientific jargon, if you have that feeling that this is that patient and you feel like you need to transport early, sell us on that story, get the MSEP online early. But don't hesitate to reach out to your 7/8s. Appreciate that. There, Captain Ferando. I'm going to move over to Lieutenant Ruscetti now. Let's just say you respond to, hypothetically speaking, 500 Louisiana and Princeton Place, which never happens, for a cardiac arrest. 56-year-old male, who knows how many comorbidities, what have you.
Last seen
It's
5 minutes ago.
Last seen, quote unquote, again 5 minutes ago. So it's a cardiac arrest dispatch. You arrive, and I just want to get in your words, in the field response, your expectations and how your cardiac arrest plays out.
All right, so I think talking about ECMO was a good platform to kind of build off of as far as how we operate, specifically because the way we do things now with the pit crew that we talk about continuously, the implementation of the Lucas device, all these things have led us to the point of this having successful outcomes with this ECMO and with our patients. So it's kind of been a building of sorts to kind of get to the point where we're at now. So to go into that, so the pit crew procedure, so we walk into this, this particular situation, maybe at 500 Louisiana. And generally, we're hoping to get some information. But while this information is being attained, it's critical that we get our crews prepared for the situation, right? So I think this specific Code Blue episode didn't start now, or didn't even just start 2 minutes ago. This started with preparation a day, a week, a year ago. And how your crews perform in that situation really dictates how the code is going to operate from there. So, going into this pit crew thing and having everybody kind of in a position that they understand, having your crew know their role in these operations is critical. For me, my expectation initially is I'm going to find out kind of what's going on, right? Why is this situation the way it is right now? What led to this situation, and can we identify a timeline while keeping these ECMO criteria in the back of my mind? Because how we operate from that point of patient contact will determine whether, we get off scene with this patient, as Captain Ferando was talking about, in that 35-minute mark, or are we staying there and digging in to really try to get this moving before the ECMO folks get there? Or just are we going to work this code into its entirety?
So you arrive on scene here, you have your engine crew and you and your rescue driver with you. Who gets assigned to what, and is there a certain succession of events?
And so going back to that, with the we don't always have the amount of people. It's assigned 8 positions in the pit crew at best, and hopefully we do get that. But initially, with the one rescue and an engine, which is very likely, you're not going to always get all those positions. So initially, it's there's a first firefighter that walks through the door. Early recognition of whether this is a pulseless apneic patient is paramount, and then compressions immediately after. And so generally that's that first pipeman that walks through the door, as well as myself or anyone else who can get hands on the patient, really determine how we're going to proceed. So that, initial continuous compressions start at that point. So within seconds, there's somebody providing compressions that don't stop, right? So we're really working towards that continuous compressions with limited pauses no greater than 10 seconds. From there, generally speaking, and I think this is where preparation comes into, one of the most important things, and one of the things that I think makes this situation most successful, is having somebody, in my instance, most of the time it's the engine lieutenant, who has the tough book and is gathering information on the side, as well as documenting things that we're doing. This creates a clean timeline of events. It keeps things organized, and it keeps my hands and my mind free to kind of go about assigning positions after that initial firefighter starts those compressions. So then I'm dictating to the driver, potentially, who's at the airway at this point. He's looking to put on end-tidal nasal cannula. We're looking for capnography almost as soon as we can start compressions. So this is happening kind of at the same time, and that's the goal, is to get that capno line on, get those compressions started, passive oxygenation, and the pads are going on for early defibrillation. That way we're ready to analyze that rhythm and make a decision whether we're going to defibrillate or not. Kind of bouncing around a little, but I think maybe that paints a little bit of a picture of how things are starting. And from there, there's another paramedic on scene with out of my truck. This gentleman or lady is looking for IV access, IO access if necessary, and making that determination relatively rapidly how we're going to proceed. From there, we start considering how we're going to move down this line of the Lucas, right? And so all this happens within the first maybe 15 or 30 seconds. This is it's a very quick, and that's where preparation comes in. We're looking to initiate all of these elements, and then we start thinking about Lucas and how we're going to proceed from there. So from that point, generally speaking, and this is different for everybody, you may have someone assigned to the Lucas specifically. It may not be the drivers at the airway kind of looking for that situation to start. Generally speaking, I have the Lucas with me a lot of times because I walk in with it. It's a piece of equipment that I just grab, and I unzip it as soon as I walk in. And in some instances, I can unzip it and pull out the plate prior to even entering the residence, which having that in hand is kind of a big deal, or at least with the thought process of moving forward, getting that into place sooner than later is ideal. All right, so now that we've kind of discussed getting through the initial steps of getting all the players in play and all of the elements in play, we have to really kind of discuss some important things that are being considered during that time frame, right? So generally considered by the rescue lieutenant who's kind of overseeing the operations, right? You're making sure that compressions are done appropriately. You're making sure that IV access or IO access is getting completed. You're managing kind of how things are getting documented, as well as also with those things come rhythm checks. And during that first rhythm check, we're determining whether we're going to defibrillate early or not. This is that first opportunity where we can really take a moment and make sure that we're making the right decision. And defibrillating early on into this event is really a big deal. If we need to do that, then that's going to be where we make a big difference. Also, because all these things are happening simultaneously, hopefully we've got access. And access nowadays is very, with the implementation of the drill, it's almost a guarantee in a sense. We spend a lot of time with a lot of sick people, and finding IV access can be difficult, but you always have that drill to use as an implement to get that IV access or that IO access in this case.
Crews rarely have an excuse for not having it.
Sure, so there's a big emphasis on taking a look, seeing what you can see, and if you can't find anything peripherally, then it's probably a good move to just go to that IO. Now, it isn't the most optimal access for epinephrine, which is kind of where we're going with this, is that early epi. But getting that epi in earlier than later is also paramount in patient success, right? So we want to get that moving relatively quickly as well.
Sure, I've heard Dr. Pruitt comment on that multiple times about early epi, and again, early recognition of those shockable rhythms and early defibrillation will probably be the patient's best chance. And then as far as recency of arrest, that kind of stuff.
And I know we're not talking about pediatrics today, but the importance of that first dose epi and that immediate CPR is huge. That really is one of the things that you look at the studies that show survival rates or ROSC rates in pediatrics, and it's that early epi is just invaluable.
And Jeff's right. Having that IO drill is it's invaluable.
And to bounce off on that, and this isn't maybe common practice, but more lately than ever, if you're able to get one IO, you're able to get two, and to have 2 points of access immediately, that kind of plays a role and will actually lead into medication administration later. But that having those multiple points of access is kind of very helpful and streamlines kind of things how they move from there also.
So now I'm thinking back to when we were initially taught pit crew and whatnot. They always told you to wait for that first 3 cycles, the full 6 minutes, before you consider advanced airway. Is that something you do as a standard practice? Or if you have all your other bells and whistles checked off, are you moving towards that? And do you have a preference, LMA, ET tube?
So I think when we started, we really kind of followed that model to a T, and we found ourselves kind of standing there for a moment and not really moving forward in the progression of things. And after that, the positions are established, the Lucas device is in play, we've checked, the rhythm and defibbed if we needed to. We've got access and we're, administering epinephrine. That airway is the next most critical thing that we need to do immediately. And if we can do it sooner than later, it's something that we do. And generally speaking, in this perfect scenario that we've talked about, kind of where things just move fluidly and in succession, you can get to the airway relatively quickly, probably within the middle of the second round of CPR. And generally speaking, if it's available, we've got the Lucas, now we've got people kind of in a position where they're waiting to do things, and we'll do things when the time is right. However, if we can establish that airway sooner than later, then we'll do it and do most of the time. That's how it generally works. As far as airway is concerned, anymore, the ET tube is kind of, I like that we have that in our tool bag, but the LMA is kind of what things have moved to, generally speaking. It again falls into that seamless, streamlined progression of how things go. It's very easy to do. Any basic on scene can assist with that and or do it, and it just gives an option beyond just the ET tube and tying up one of the medics who could be, performing other tasks.
Sure.
And I encourage rescue officers and engine officers to have their pipemen or their drivers use these LMAs. I think it's important that we all stay proficient in this task.
I think from the realm, just to chime in from the realm of quality assurance, that my biggest overarching thing is thinking back to earlier days as a paramedic where the pride kicks in for that medic. And so you're looking at prolonged intubation attempts and prolonged amounts of time where the patient is, again, without oxygen. So I would hate to think that we're contributing to that anoxic injury that the patient may have, ultimately in the emergency department.
Especially in those early days, you'd stop compressions, you'd stop ventilation, so everything halts. And then, it's not what our standard is, 1, maybe 2 attempts if you feel that you can accomplish that. And this is a concurrent with compressions now. But back then, it was not uncommon to see 10 attempts with 2 different providers over several minutes, and maybe some moderate compressions with some ventilations in between. And just getting back to like Clint and I's role in these codes. So Jeff will have accomplished most of all this stuff within the first few minutes. It sounds like a lot to do, but I know that these guys are knocking out all these critical interventions within that first 6 minutes. Everything's usually done. Clint and I just, since our geographical position's not in District 5 or wherever, we're coming across town, so we're arriving late to the party. And when it's you walk in, and for us it's kind of not that we're going to take away Jeff's scene because you're the LT, you're in charge of this. Our role is what can we do to help you? And at that point, we're carrying some tools in our truck that are making these codes, even easier for crews with the ventilator that we now have. Ultrasound that we carry, it's kind of making that patient care decisions a little different.
Yeah, and I wanted to throw in my own little aside, just considering the current issue we have with everybody's concern with Corona, PPE, all these kinds of things, just to reinforce that on those those confirmed 9 echo calls, everybody's down and dirty in an environment where our exposure potential is higher, so we still want everybody in full PPE for these codes, especially like Jeff was saying, if we get into that airway, this is the opportunity where the potential to aerosolize droplets is definitely increased. So if you have somebody in there intubating, whatever, wouldn't hurt to have those goggles on and the face mask. But again, just to reinforce, that's what the posture is right now, to keep everybody protected.
And intubation does aerosolize those droplets even more than the supraglottic or extraglottic LMA device. So in our current situation with this, COVID-19, preferred definitely airway is going to be the LMA.
I couldn't agree more. And just, again, I think that's an argument. I can't say I was always in that camp anymore now. I think it's cleaner, it's easier, and at this point it's safer. It just makes sense.
Yeah. And we don't want to make this a diminishing scale where, my last intubation was 3 years ago, my last intubation, or did 2 last year, whatever it might be. Sure. We still want our guys to remain proficient, but not at the expense of a patient care.
Exactly. So since we're on the topic of airway and kind of, those are all great points. Once we establish that airway, though, now we need to really consider what we're doing with it. And there's a few things that need to be done. We got capnography on the patient. We're doing, passive respirations with a mask possibly while we're kind of moving through critical tasks. Well, now we're at a point, we've got an airway in place. We need to reestablish that capnography. And a lot of times adding that prior to even inserting your LMA, that becomes common practice. You fit the LMA with that capno line and then insert. You don't miss anything. And if the next person comes and he's there with the bag and just applies it, it doesn't get forgotten. So that's something we try to do as well. Keep those things together. It's almost, you take one out, you have to take the other out. You apply it, then you establish your airway, and then you just start bagging. Now, in doing that, you do have to switch the lines because, you want to get the reading off of the correct line, but having it in place is kind of mindless in a sense, and if it's already taking place, then it's just done. Capnography, we can go into some detail about it, and I think maybe a little bit more down the line as we keep talking. There'll be some more points to hit, but just some kind of overriding thoughts, I guess you could say. This is very predictive of ROSC. You can predict to an extent acidosis, ventilation effectiveness. And most of all, it's the gold standard for tube placement. Are you ventilating this patient appropriately?
Do I see a flat waveform or do I see a nice continuous?
Correct. And are you getting a numerical value with this? Because if you don't, oftentimes you don't have placement correct, and there needs to be an adjustment somehow.
Correct. We're not satisfied with just seeing that continue.
Exactly. And this is way big for ET tubes. Making sure you don't have that gut placement. But for your LMAs, it's the same thing. We're doing this for a reason. We want to make sure we're doing it correctly.
So, Jeff, you've confirmed your placement. You have good waveform. You have good values. Good quantitative capnography. What's going to tell you that you might think? And again, we're going to get into this a little bit, but that your patient is acidotic. And what are you going to do to resolve that, or what can you do through your ventilations?
Initially, if we've got this capno line on, so generally speaking, you're going to have a low capnography or a low end tidal reading on these patients. And if it is high, there's some things that you can kind of consider. So one of those being, is this a respiratory arrest leading to cardiac arrest? You got a high end tidal of these folks with COPD. Maybe it's an asthma related event. They air trap and you see, and if this is early on in the event and you see that capnography is super high, there's a pretty high index of suspicion that this possibly could be a respiratory component, which kind of leads you in a direction of how you're going to go with that. And in situations like that, a high end tidal, you would bag a little bit quicker to try to get that end tidal down a little bit to that 35 to 45 mark. And if we can kind of get to that point, then that's where we want to be. But more common, you'll have a low end tidal.
So, Jeff, from there in the realm of keeping our capnography and reading, so you've placed the tube and you're not getting a waveform, or you're getting a dotted line or a flat line. How do you like to troubleshoot those?
I think initially you troubleshoot the connection point into the life pack itself. Those can either be over tightened or under tightened, or even moving more towards the end, the working end of maybe the tube is crimped or pinched off somewhere or tied in a knot. Things like this happen. I think you look at those things first, kind of move down the line, and if you do it systematically, you can kind of figure out those things relatively quickly. Also, you want to consider some issues. If you're not getting any waveform or any numerical values with this capnography, maybe your airway is clogged somehow. Did this person, is there emesis in there? Is there blood? Those sort of things, which would require you to suction and make those adjustments as well. Did you check the person's airway? Is there something there? What were they doing prior to the code? If that information is available, it could be a choking call that led to this, or one of those things. And then moving forward, if that doesn't work, try different equipment. You have more than one LMA. You can add air, you can take air out. You can also adjust your tubes or your lines and change your capno lines and move forward that way as well. And generally speaking, you'll be able to overcome any of those issues pretty quick and efficiently by doing it that way.
Sure. And I think the overarching thing with this and with airway in general is we like continuous quantitative capnography. We understand that really is the gold standard for confirming where our tube is placed and whether it's placed correctly. And we're not satisfied with no value, and we need to troubleshoot and figure it out. If you need to go back to your old clinical lung sounds, misting in the tube, what have you, as long as that stuff is documented and you're able to verify those things, it's not the end of the world. We'd prefer that capnography, but again, we can go down a whole ventilation respiratory issue wormhole with that.
Absolutely. And using your tools, like you said, listen to lung sounds. Those are basic skills, and basic BLS is what's going to make the difference in this event ultimately anyway.
Yeah, and we don't want to lose sight of that. Again, like we haven't interrupted chest compressions. So what we've done is we've laid the groundwork here on this on Jeff's code. He has assignments for continuous chest compressions. He's got the airway covered. He has access. He has early defibrillation, early epi. We're continuing to monitor what the monitor looks like every 2 minutes when we take our pauses. We're beginning to evaluate different things. So we see different circumstances, different presenting rhythms, different things leading up to these cardiac arrests, and that's how I'm going to kind of digress and segue over to Captain Ferando here, who's going to kind of take us into the various presenting rhythms, possible causes, and that kind of stuff. Take it away, Kevin.
All right, thanks, Clint. So I think one of the more common rhythms that we see is probably a PEA, or a PEA going to an asystole, or an asystole going to a PEA. I don't want to say there's an easy algorithm to run, but it definitely keeps us. It's a little bit more the flow of an asystolic code is pretty much our continuous chest compressions and epi. So real quick, how our new guideline is structured as it pertains to asystole, some of the no's, no more Narcan during a code, no more D10 during a code. So there's just no efficacy shown that those are beneficial to these people, even if it was the causation of a possible code. We can address that post-ROSC. Another big highlight to the new guideline that we're working under is if it's an unwitnessed arrest and it's an asystole upon your arrival and it's a sustained asystole with no changes throughout, we are now DCing at 20 minutes without an MSEP call. And so I've been through a few of these already. The first one is very surreal, you want to say, because it's just not something that we're not used to not calling that. The MSEP consortium doc for those DC orders, at least getting that that medical direction that we're so used to, really to kind of drive it home. The guideline is nice. It gives us a lot of that anonymity now where we can make these decisions. As far as what we're kind of looking is for the asystole arrests or the PEA arrests, just like Jeff had said, it's going to be you show up on scene, you're going to start your treatment, early epi. IV access, early epi, continuous chest compressions. We're minimizing those pauses of 10 seconds or less, hands off the chest or Lucas off the chest, whatever you want to call it. These are giving these patients the best chance of survival. So I just want to go over the H's and T's. This is something that we're going to be looking at or thinking of with every pulseless arrested patient that we have. I'm just going to read down the list. So, our first H's will go hypoxia, hypovolemia, hypothermia, hyperkalemia, and how we're going to treat those H's is, so if it's hypoxia, that's that respiratory, that respiratory arrest will always lead to that cardiac arrest. At some point, your heart will stop if you're not getting oxygenated. So is that what caused it? Was this a COPD event? Was this a severe asthma attack or an anaphylaxis? And that's going to kind of lead us down different treatment courses too. You're going to be thinking MAG. You're going to be thinking other medications that are going to be able to maybe open up these smooth muscle relaxants. It's going to get this patient that oxygen they need to get that heart going again. As far as hypovolemia goes, that's that fluid loss. And so is it a pump problem because they have no volume? So that's when we're going to give these 500 cc boluses to get that hopefully that volume up, get that heart, something in that heart to actually pump against. As far as hypothermia, we'll see a couple of these a year. These are the ones, maybe an individual outside who, arrests, and these can be tricky because you don't know if the hypothermia caused the arrest or if they arrested and then they just happened to be in a cold environment. So we're going to treat it a little differently. They're going to go a little bit slower. It's going to be that extended pulse check because they may have a pulse. They may have that it might fool you into thinking that it is a PEA without a pulse. So we're going to be listening, or we're going to be feeling for 30 to 45 seconds to see if we can get that. Everything changes a little bit with a hypothermic arrest. We're only going to defibrillate once, and we're only going to be giving epi once. And now we will more than likely transport these individuals, even if we do not get that ROSC that we're used to, just because we're not going to be able to efficiently or successfully say, this person is, how's it go? You're cold and you're not dead until you're warm and dead, not cold and dead. I mean, it sounds...
I was going to piggyback onto that. Dr. Pruitt has told us that the hypothermic patients seem to be the ones that benefit the most from ECMO, where she's had that hypothermic patient go into arrest in front of her in the ED. They have that patient on ECMO, and she's talking to the same patient in the ICU the next day. So there's a lot of potential for good outcomes in those patients. So all the more reason to transport them.
Absolutely, and I know even with our arrest patients, the passive cooling is still not uncommon. I don't know if it's not high on the list of people's minds, thinking that I should get ice packs and put them under armpits, but it's actually helped with showing positive outcomes. We can also continue down the H's. The last one is going to be hyperkalemia. So these are going to be people with that renal insufficiency. So your dialysis patient. These patients I have actually seen a lot of times where, we're just not arbitrarily giving sodium because you think of downtime. We're not giving calcium because of, they've been down, they're acidotic. If you have that high index of suspicion that this person missed dialysis, their heart was very unhappy because of that cardiac irritability from their potassium levels being so out of whack that's what caused the arrest. So once you start your ACLS interventions, then you might start thinking out of the box. Like Jeff said, get that detailed history. This individual, they didn't make it to dialysis yesterday. Now you start thinking, all right, maybe we got to get this potassium back in this cell. So we're going to be looking at bicarb. We're going to be looking at calcium, maybe even bagging in a nebbed albuterol. And so these are things that really start getting you, that's as a lieutenant especially, these are considerations that you're like, okay, what are we missing? What are we hitting? And so, and I've been present on several ROSCs when we have done some of those more outside the box kind of thinking.
Sure.
So
that bagging in that albuterol, does that go in the normal dosage?
So if we look at our T's of those H's and T's, the tension pneumo, tricyclic overdose, and you're going to look at your trauma. So, and those are all going to lead us down different avenues. Not as many T's that we can reverse. When these people are arrested, even the tricyclic overdose, it's something that's usually when you start seeing those, it might be, if they've arrested, that's already a late indicator. Bicarb is going to be the treatment for that tricyclic overdose. If it's a toxin issue, maybe we can start thinking about the bicarbs and the calciums. As far as trauma goes, that's usually a volume problem. So we're still looking at plugging the holes, patching, volume replacement. Hopefully we can get a return to circulation there. That's going to be a whole nother topic as far as our trauma arrest goes. As far as the PEA side of it, these are going to be a little bit longer codes that we're going to work. So we're, instead of looking at that 20-minute as opposed to asystole, we're going to be looking at a 30-minute time because we're giving this person the benefit of the doubt. There's a rhythm that we're seeing electrically. We're just not feeling a palpable pulses. Whereas now the 7/8 and some of the other guys in the field, even though 7/8 are the only ones who are carrying the ultrasound, we have a bunch of folks that can use the ultrasound. So if I show up and Jeff happens to be one of the guys trained on the ultrasound, I'll hand it off to him. He can get looks at the heart, and we're now seeing whether this heart is actually giving us a perfusable beat, or if this PEA is just a mild quiver of one of the valves or one of the chambers of the heart just still trying, but not being effective at actually pumping any kind of blood and giving us that palpable pulse. I know Clint, you might want to tell your story that is kind of leads down that PEA or that cardiogenic shock, which we're starting to think about on some of these PEAs. I've maybe had one. I know Clint's had a couple where the ultrasound was invaluable to that. Clint, you want to?
Yeah, without a doubt. And I mean, this was a 46-year-old female who did have comorbidities, came in as a 6 Delta with 7s, and it was a witness arrest in front of our crews. So they knew about the bystander CPR. They knew about all these other boxes that would have or could have been checked for ECMO. What confounded these guys was they had an increase in the end-tidal value and a corresponding increase in the pulseless electrical activity rhythm they were looking at. So a rhythm that went from about 50 to 80, and then about a 20-point increase in the continuous quantitative capnography without any actual palpable ROSC. They couldn't feel pulses, but when I looked with the ultrasound, I saw what looked to me as a good beating heart, what I would qualify as squeeze. We were able to get Dr. Pruitt on the phone, who was able to give us an order to transport without pulses. And this lady ended up walking out of the hospital. And this, of course, is one of the more rare occasions. But again, this really does tie into you guys, your field impressions, and that spidey sense, that awareness, that feeling that, you know what, this situation doesn't seem right. I feel like I should be feeling pulses here. Why am I not feeling pulses? And if you feel strongly enough about that, and even if 7/8's not there, if you feel like this person might benefit from a continuous drip, sort of going down the cardiogenic shock route, then get that MSEP on the phone earlier rather than later and see about that. And we'll talk more in depth on our ROSC lecture there about drug indications.
But you're thinking about those pressors. You're thinking, why is this? You've looked at your H's, your T's. What if we tried to correct and it's not working? So then you're starting to think, well, maybe we need to bump the squeeze on this heart. And so we start looking at our epi drips and our mini boluses. As we're talking about moving from that asystole, we're moving into that PEA rhythm. With our PEAs, having the ultrasound does make it a lot nicer because we were really looking to see if we have that cardiac squeeze. We have these individuals who say are perfusing at 30 beats electrically. We're not seeing any squeeze on the ultrasound. We'll work that 30 minutes. We're following the same medication algorithm as your asystole. It's going to just be your epi every 10 minutes. And so what makes it a little bit more hard to decide or DC these calls is when you get this PEA of 60, 70, 80, and now you're working this code for beyond the 30 minutes because you're thinking that there might be a potential ROSC, especially when you have a more narrow, complex, organized rhythm that's electrically showing 60, 70, 80 beats a minute. There again, ultrasound really is huge in this because we can take a look. And there's almost very predictive. If you see what looks like an organized squeeze, but you're not feeling pulses, a lot of times you'll say, all right, where are we at in our last epi? Where are we at to get our next epi? How much fluid have we given this individual? And then, if it might just be that little epi bump that gets that organized rhythm, and it's not uncommon to see a little bit more cardiac contraction with that. However, that next pulse check, that next view with the ultrasound, if you're either going to get a stronger beating heart or usually a decreased is what I have seen. So now you're looking at your third, your fourth pulse checks post, say, an epi administration. Even if it's at that greater than 40, we're going to work that code out to 40 minutes. And, at that point, there's probably going to be futile to continue our efforts, so we'll get those DC orders. Mm-hmm. So, one thing, though, working any of these codes at any level, though, I think Jeff touched on it, but good BLS goes so far. So we're really keeping a lot of this stuff basic. It goes back to what we were taught, BLS skills, ABCs. So it's chest compressions and it's ventilations. And so everything else we can start, building upon that, really get that detailed history, and maybe that'll change how our course of treatment takes place. Cool. Clint, I'm going to have you go into VFib, VTAC. I know that you will give us the topic on that and see how we can run our calls from there.
Well, I appreciate that, Kevin. So just going to real briefly touch on this because there will be a different podcast that can go specifically into tachycardias, reasons why, medications given. medications that could cause it, pre-existing, congenital problems that could cause it, that kind of stuff. But what we're looking at is in the context of cardiac arrest. So in the cardiac arrest, you've seen your asystole, you've seen your PEA, and now in this instance, we see either a ventricular fibrillation or ventricular tachycardia. Most folks know how to recognize these. The automatic external defibrillators will recognize and advise shock. So we see that with the adult. We're not going to go down the various rabbit holes that we could for every patient population, but this just in the adult population, we're shocking at 360. And after this, or if we're seeing subsequent presentations in the VFib or the VTAC, we're going to continue to shock. We'll be giving Lido as well. Those doses, again, we'll go into detail about those. But the lidocaine being an antidysrhythmic, trying to calm this agitated state in the heart. What you need to know about these rhythms, though, is oftentimes it's created by that acute coronary syndrome, which you can refer to in your guidelines. But in essence, this person has that pre-existing condition, that blocked artery, that probably a presenting STEMI. So this person had that sudden heart attack. And if you're seeing these rhythms, probably means it happened recently. So, our thought with these is that these are going to be some of our better chances at getting these folks back. But it is going to change our algorithms, change the medications we give. We're also going to consider things like magnesium sulfate, depending on the presenting rhythm being a tachycardia. And then, we'll talk more specifically about that in other lectures here. Again, just to reiterate, as Kevin had said, you guys know by now all the details, how far, how long you're going to go with each presenting rhythm, and all the other information you get on scene. When you're going to call the doc, when you don't need to call the doc. Obviously, we're not going to talk about trauma arrest. That would be a different podcast altogether. Appreciate you guys listening in, and stay tuned for the next discussion on ROSC, what to do after.